Welcome. I want to introduce Ned Schwing. Ned, tell us a little bit about your background and what it is that you do, and then we can chat a little bit about how the environment right now has changed so much for physicians in decision making, and why one of the things that you've been very involved with may be a very interesting alternative for physicians as they're trying to make decisions right now about how to practice medicine.
Sure. So I guess I'll start by saying I'm a serial entrepreneur, which is, for lack of a better term, what I have sort of coined what my background has been over the last 23 years. So I've founded 6 healthcare companies, co-founded along with my brother Robert, and we have partnered with physicians. We've done about 60 joint ventures over 22 years and created opportunities for physicians to invest through ancillary healthcare ventures. And really, it's a timely topic today because, as you know, physicians' incomes have been declining pretty significantly over the last few years, and so this topic of ancillary investment has been a real hot topic these days.
So we just had a session this afternoon, and we're going to be involved in one a little bit later together, and really the world is kind of becoming dichotomous. You're either an employed physician or an independent physician. So how do you appeal to the scared physician who's trying to make that decision about should you become a hospital employee or not, recognizing that you don't offer a specific alternative, but you do offer an idea that puts you a little bit more in the driver's seat. So how do you approach a physician that's concerned about that right now?
Well, I think the operative word is fear, and that really is what we've seen the primary impediment of physicians in terms of remaining independent. And so, as you know, fear is never a great place to start with an investment opportunity, or at least a way to build a business. It should be born out of opportunity, and where there is a great deal of fear and uncertainty, given the regulatory changes, reimbursement environment, we've seen a lot of change, and that creates fear, but it also creates opportunity. So it's really up to us to just provide an opportunity for these physicians to understand, hey, here's some options. This is not the cure-all, but here are some options that you have.
You know, one of the arguments that the large systems will have is that they provide data and they provide outcomes, and the government's looking for these, you know, markers and benchmarks of quality, and they use the words as if they are, you know, so ubiquitous in the large healthcare system. But I know that through your organization, NCP, and others that do this, that the quality, the patient satisfaction, all the endpoints that the government's looking for can be met maybe even better in a facility like the one we're talking about. Tell me a little bit about how that's a focus for you.
Yeah, so quality is critical, and particularly if you're going to deal with the kinds of physicians that we deal with. So you can't start with I think a productive venture unless you're talking about quality. We measure 22 key quality indicators. We measure outcomes and data, and so I think we're preparing for the day when you know, these institutions will be paying for that quality. And we're in a unique situation now where we've got great operators, great partners, people that do care about quality. It's an efficient place to work in our labs. It's a less expensive place to work for the patient, which is critically important. High quality, low cost. That's really the mission on the Hill right now these days.
Absolutely. So let's talk about that for a minute. I mean, one of the things that we keep being bombarded with is this idea that, you know, without all of this quality and with all these systems in place, that your costs are going to be higher. And that, I mean, is that true at all? Do you think that in a facility like the ones we're talking about, outpatient centers, that the quality and the cost effectiveness isn't directly in competition with a hospital? How could we possibly be more expensive than a hospital?
Well, I don't think we can. Yeah. I mean, that's the bottom line. And if you look at the parallels between what we do in our outpatient labs and what has been done in the ambulatory surgery center industry over the last 30 years, there's been a migration of surgical cases out of the high cost center, which is the hospital, and into the lower cost setting, that of the ambulatory surgery center.
How do we fight what seems to be a very uphill battle? I mean, obviously in Congress and CMS, there's this pushback on the payment, which obviously leads to difficulty in opening more centers. But more importantly, the hospitals and their systemness continues to increase their push towards employed physicians and physicians who ultimately, you know, won't be able to refer to centers like this. So what do we do as those that want to stay independent that make sense out of this?
Well, I think if you look back to the kinds of procedures we were doing 5, 6, 7 years ago, we were primarily a diagnostic left heart company, cath company. Today, we're doing, as you know, a full scope of services, full modality, and reimbursements are going to continue to fall. So don't let anybody kid you. They will continue to fall. We can react to that out of fear and quit fighting the fight, if you will, or we can continue to fight and do the right thing. And we think that those codes will continue to migrate out, as I was talking about the ambulatory surgery center, those higher acuity codes will continue to migrate out of the hospital setting. So where we'll see reduction in existing case volume reimbursement, we're going to see higher reimbursement offset from new codes that will be released.
Do you see a way for there to be some collaboration? So physicians in general have worked traditionally in hospitals. This is an alternative for us, but we really don't want to, we personally don't want bad relationships with our hospital partners. Tell me a little bit about how you think that this may, play out over time so we maintain those relationships.
Sure. Well, we're already starting to see systems do three-way joint ventures with physicians and other companies like ours. We have a platform in Houston with 4 joint ventures with the Methodist healthcare system. And so I think we have proven that this model works. Hospital administrators that are looking forward in ways to partner with physicians as opposed to just become a true employer of physicians, I think we'll see this as a great venue and opportunity for them to grow their business and capture market share.
You know, the government has put out all of these opportunities for research, which are physician-centered, these PCORI research grants, and I wonder whether one of these such grants might be useful to really evaluate and inspect what we're doing in the outpatient center as a viable option for some of these government monies instead of going back into the hospital system. You think that might be a good place for us to take all the centers that you have now and maybe put them into a good database program so we can really understand why we do things and how we do them?
I love that idea. Absolutely. I think that's a great idea.
Great. Well, Ned, thanks a lot. Thanks for being here this afternoon. We've got a great session later, and I hope we'll be having a more conversation about this and really, be able to flesh out the differences between the independent and the employed physician and see that there could be some significant collaboration over time.
Well, I appreciate that. Look forward to it.
All right.
Thanks, Tony. Yep.